Thank you for joining us this morning. Our first speaker is Riati Scarborough. She's a PhD fellow at the National Centre for Antimicrobial Stewardship at the Faculty of Veterinary and Agricultural Sciences at Melbourne. And she'll be talking about antibiotic use, improving antibiotic use in Australian veterinary practice. Thanks, Rhi.
Thanks, Arjun, and good morning, everyone. Thanks for joining us for another pandemic lockdown edition of NCAS Journal Club. For those of you joining us from overseas, an especially warm welcome. It's always nice to see that our work that we're doing here is being heard beyond our local sphere. For those who haven't met me yet, I'm Rhi. I'm a vet and a PhD student with NCAS. I've just passed my 1-year PhD milestone, and today I'm going to share with you some of the work I've been doing for the PhD. Navigation. There we go. So just quickly about why I chose this topic. I think AMR is, and I'm sure I'm preaching to the converted, that antimicrobial resistance is an urgent global challenge. And I think that veterinary prescribing and pet owner compliance are key ingredients in this challenge. For those of you outside Australia, vets in Australia must prescribe all antibiotics that are given to animals, and they tend to also dispense the antibiotics, which is not the same as all countries. This problem is at the interface of human and animal health as well as the environment, and I find that an interesting space to be in, and I'm really interested in the psychology of behaviour change as much as the microbiology of this. I guess the next question is, why would I try to focus on small animal practice? It's because I'm familiar with the subject matter. It's what I have done most work in, and there are known opportunities for improving prescribing in this space. There's been a lot of work done by some of my colleagues in the veterinary faculty showing that we're not using optimal prescribing habits at the moment, and it's really important because there are very few limitations in Australia on the types of antibiotics that can be used in small animals compared with, say, what can be used in livestock, which is quite restrictive. There is a lot of use of different antibiotics in small animals, and we have some particular challenges at the moment with a couple of critically important antibiotics. There are some, these two are ones that I've focused on. The first one is called Convenia, and I'll speak a bit about this later. It's a third generation cephalosporin. It only comes in an injectable format, and a single dose lasts about 14 days. So that's a pretty heavy treatment. Another one that's been around for a bit longer is an enrofloxacin quinolone that's available in injectable, oral and topical formats. The topical is used mainly in infected dog ears. This is important because there's lots of close contact between pets and their owners. Here are some pictures of my children with our pets. We have very close contact, and we know that there's transmission both ways of pathogens. We know that that there have been cases of MRSA passing from owners to their pets, and MRSPs going from dogs to their owners. So there's plenty that's being transferred that we don't know about as well. I find it really interesting that this is also quite a similar space to the human general practice setting. The vet owner animal triad is quite similar to the GP parent child triad. So I think there are good opportunities for the veterinary profession to learn from what's happened in GP and vice versa. And it's nice that in NCAS we have that One Health approach, and we can share that knowledge between the different stakeholder groups. So this is a quick overview of what I'm doing with my PhD. There are 3 main phases: an evaluation phase, an exploring phase, and then an intervention phase. I'm doing a little bit here and all over the place. It's not linear, but I'm not going to talk through everything today. I just wanted to talk a little bit about the antimicrobial resistance in dog and cat urinary isolates that I've done, and then I'll speak about some vet interviews. So this is a friend of mine from my year level in vet science, and he's a veterinary pathologist at a local laboratory here in Melbourne. And he's been very generous and given me access to 5 years of culture data from dog and cat urine samples. There were 5,614 culture positive samples in this, and they came from 4,635 individual animals. So you can see that some of the animals had repeat cultures. The lab uses the CDS method, or the calibrated dichotomous susceptibility method, to determine whether a bug is resistant or susceptible. Just a refresher on that, they measure the zone of inhibition around each antibiotic disc, and if it falls above or below a certain cutoff, it's called resistant or susceptible. The cutoff measurements are another matter, but I'll touch on that a bit later. So these are the bugs that grew in the urine samples from dogs and cats. As you can see, it's really a story about E. coli, responsible for almost 60% of them overall, with some Enterococcus faecalis, Staph pseudointermedius, some Proteus, Enterobacter, and a little bit of Streptococcus canis as well, but mainly about the E. coli. This is, as a bit of background, the reason that I thought this study was important was because we do have local and international guidelines on this, on treatment of urinary tract infections in dogs and cats, but the treatment recommendations are largely based on international work, and there haven't been any large-scale antibiograms done in Australia to date. So this is quite a big set of data, and quite helpful to know what's going on locally. Before I show you the antibiotic susceptibility table, I wanted to introduce the concept of antimicrobial importance ratings, which most of you are familiar with, but there are different versions of it, and this is the local version, the ASTAG version, which are based largely on what the WHO has done, but with some differences based on our local pathogens and resistance profiles. And unlike the WHO ratings, the ASTAG ratings are a simple 3-tiered system with low, medium and high importance antibiotics. And the basis of these ratings is really about, if we get resistance to this antibiotic, what have we got left to treat the important pathogens that we have here in Australia? So the higher the importance rating, the fewer alternatives available and the more care that should be used. And you notice that I've used a green, orange and red colour coding system here, and I'll repeat that throughout the rest of the presentation. So it's clear what the importance ratings of the drugs are. So what do we know about what vets are doing with UTIs in small animals in Australia? Well, my supervisor Laura and colleagues have done some work on this from some pet insurance data, and we know that most dogs that present with urinary tract signs are being treated with amoxicillin clavulanate or cephalexin. And in cats, they've been treated with the high importance agent cefavecin or also amoxiclav. So we know what's happening out there, but what is actually, what does the antibiogram say? Before I show you this table, I should highlight that in the veterinary world, because owners are required to pay for the entire cost of a culture and susceptibility, which can cost a retail price of about $250, culture and susceptibility tends not to happen until, say, the second or third presentation of a urinary tract infection. So the animals that make it into this data set represent a highly selected sample. They've had either treatment failure, relapse or complications. So lots of them have had previous antibiotic exposure, and that may affect what comes out in this susceptibility table. And I know tables are a bit tricky to look at in presentations, but I've tried to use colour to help guide what to look at here, and I'll talk you through it all. The top line is we have all the antibiotics that were tested in the laboratory against different isolates. Sorry, I've abbreviated them all, but amoxicillin, trimethoprim sulfonamide are the most important ones here, amoxicillin clavulanate, cefalexin, cefavecin, and that's enrofloxacin over there, and I've colour coded them according to their importance. Down the side, you can see all of the bugs that grew and their relative prevalence, and then these cells show the percentage of susceptible isolates. I've colour coded the cells here, so anything that's grey you can essentially ignore because either it's intrinsically resistant or so there were very few isolates tested, so we can't really say very much about it. And everything in green is really good news. It's more than 80% susceptible. And as you can see, most of the green cells here are actually well over 90% susceptible. There is, however, some lower results. The yellow results are between 60 and 80% susceptible. Somewhat bad news, but with a little caveat here that these drugs with asterisks on the top are highly concentrated in urine, especially amoxicillin, and that would be highly concentrated in urine. And the cutoff levels used to determine susceptibility here don't take into account the high concentrations that you get in urine of those drugs. So what I'm trying to say there is really, all of these numbers are probably underestimates of the real in vivo susceptibility to those agents if you treated a UTI with amoxicillin, for example. So the other thing to notice is some very low susceptibility in Enterococcus faecalis to enrofloxacin, and also in strep canis, and also some intermediate values here for tetracycline against Enterococcus faecalis. The last thing I want to tell you about here is the antimicrobial impact factor, and this was a way of assessing empirical therapy that was suggested by Blondeau et al. In 1999, and it's really just a measure of prevalence and susceptibility. You get it by multiplying the susceptibility value against the prevalence, and then adding them all up for that drug until you get to less than 2% prevalence. And what it represents is the percentage of cases that you would expect to be, I guess, cured if you gave this drug empirically in a urinary tract infection. But if we look at that alone, the highest performing drug here is amoxicillin clavulanate. But is it the best choice? So, to further explore what would be the best rational therapy for urinary tract infections, one of my colleagues encouraged me to simulate using antibiotics at a population level and seeing what bugs would survive and then what I'd need to treat those survivors with. So I did that with 3,617 dog isolates that had been tested against a panel of 6 standard antibiotics. And again, I've colour-coded those antibiotics. And we found that amoxicillin clavulanate works really well as a first-line empirical therapy, but so do some of the other drugs. So then I took the took the bugs that remained and applied a different agent as a second-line therapy to see what would mop up those infections, and saw what the combined success of that combination of two different drugs would have. And you can see that the results are fairly similar across all of those different pathways. And I thought that wasn't very helpful in terms of deciding what's a good empirical therapy. We really needed a way of quantifying what the different AMR risks are of the different pathways. So I made up my own method of calculating an antibiotic cost per cure. It's a fairly arbitrary way of doing it, and I know it's not perfect, but I tried to take into account prevalence and susceptibility as well as the importance rating. And to do that, I allocated a score of 1 for any drug that was a low importance drug, 2 for any medium importance drugs, and then 3 for high importance drugs. And I know there's no science to say that using enrofloxacin is 3 times as bad as using amoxicillin, but this is my imperfect system that I hope is still somewhat useful. So when I did that and then divided the number of courses of each type of antibiotic by the number of cures I expect, we came up with a pretty clear winner of a pathway using trimethoprim sulfonamide first line, and then following by with amoxicillin for any cases that were not cleared up. This is nice because it validates the international guidelines and also our Australian guidelines on treating urinary tract infections in small animals. But as you can see, it's not what we're actually using. Amoxicillin is used in 1 in 30 cases, and trimethoprim sulfonamide is almost never used, despite it being quite a good choice. There's some fears around some complications with trimethoprim sulfonamide, so I'm not sure how well founded they are, but certainly vets are very nervous about using it in some dogs. I repeated this simulation in cats and I found the exact same pathway of using trimethylsulfonamide followed by amoxicillin resulted in the best antimicrobial cost per cure. But unfortunately, cats really hate trimethylsulfonamide, so it's not very useful for them. The next best cost per cure was using amoxicillin followed by amoxicillin clavulanate, which you can see the dotted lines here. So going by this simulation, this would be the preferred pathway. And this is in line with the international guidelines and also with our Australian guidelines. But as you know, we're not actually using that at all. And amoxicillin, which is a great first line choice, is being used in very few cats. So one more analysis that I did here was to look at how else can we help vets to choose between trimethylsulfonamide and amoxicillin, for example. And I ranked the impact factors for different situations, and I decided, well, perhaps if we knew the gram stain, which is something that can be done at point of care in vet clinics, they're usually equipped or almost equipped to do that. And if we do that, I'll just race through because I'm looking at the time. If you do a gram stain and find that you've got a gram positive, then it really changes the equation. The ranking of amoxicillin goes up much higher, and the difference between the most popular treatment, amoxiclav, and amoxicillin becomes quite small. So you'd need to treat 29 patients with amoxiclav to get one additional cure versus using just amoxicillin if you know that it's a gram positive. If it's a gram negative, trimethylsulfonamide comes up much higher and again narrows that gap so that you have a much smaller difference. So I thought this might be a useful thing for a clinician who wanted to go that extra step and do a gram stain rather than doing a culture and susceptibility. They could do a gram stain very quickly and very cheaply, and they could make a more informed choice on their empirical therapy. But the take-home messages from my analysis of all of these is that it's a very good news story, really. There is not a lot of acquired resistance in Australian dog and cat urinary pathogens. Enterococcus faecalis has high resistance to enrofloxacin. Enterococcus is generally less susceptible to quinolones anyway, but this is very, very high resistance compared to what's been published. So something that we should be aware of. Another thing that I found that with those animals that came back for multiple urine cultures over the 5-year period was that the antibiotic resistance in their isolates increased with each successive sample. So we know that there's resistance probably due to their antibiotic therapy. But overall, it's really good. 94% of the isolates were susceptible to at least one of the low importance antibiotics. Only 1% were resistant to all the low and medium importance agents. And of those, only 2/3 of those resistant were, so 2/3 of those were treatable with enrofloxacin. So I would say that 0.7% of all of the isolates had justification for using enrofloxacin or Baytril, but absolutely none of the cases in that were resistant to the low and medium importance agents was susceptible to cefavecin. So there was no microbiological justification for using cefavecin at all. So why do we use it so much? Well, this is why it's used in cats so much, because cats are very difficult to give tablets to. Sometimes some of them are difficult to give liquids to as well. They really can be quite difficult for owners, and there are a number of other reasons as well why convenia has been so popular, and I'm exploring these in some interviews that I'll tell you briefly about. So I'm doing some interviews with vets to find out what factors contribute to suboptimal prescribing in small animal practice. And I'm also trying to explore what interventions might help vets to prescribe antibiotics more carefully. And I've been doing lots of Zoom interviews at home. I've done 20 so far, 21, and I'm going to do another one this week. And I've recruited them through various means. I've got a really good mix of vets from different age groups, from different parts of Australia, different types of clinics, and different levels of interest in AMS as well. And that's been really interesting. I haven't analysed it yet, but I'll quickly tell you some quotes because I think these are always fun. The attitude of some vets to antibiotics is that they're this benign thing. Just hand out some antibiotics, no harm done. I probably overuse amoxiclav because it seems safe, like you can use it in pregnant dogs, you can use it in young dogs, and I feel like it covers 90% of problems. Some vets acknowledge that there are downsides to using antibiotics when they're not indicated, but that using them is often a form of self-preservation. Often given antibiotics is risk aversion. You know, damned if you do, damned if you don't. I might as well cover my ass. Excuse the language. Vets said that there were lots of non-clinical reasons why they give antibiotics. An older vet said to me, my boss impressed on me as a new graduate to always get the owner out of the door with something, with some medication. And a younger vet said, or you just know the owners are going to be difficult and you kind of feel that I've got to do something. If there was a pill, maybe ethoxyllin, and it's just a capsule full of air and you could just give it to not be in trouble. Some vets also had some really good techniques for talking to clients about antibiotics and a lot of success in avoiding unnecessary antibiotic use. A couple of phrases that I use all the time with clients who are a bit pushy is, I'll say to them, well, my job is actually to be your animal's voice and to tell you what is the right thing to do for this animal. And that might not be what you want to hear. So I'm doing some a mixture of inductive and deductive analysis, I think. I'll skip this quickly because of time, but I'm essentially going to be looking with my deductive analysis using the COM-B model to look at the capability, opportunity and motivation that results in prescribing behaviour. And here are some thoughts that I've had about what the different factors are under each of those headings. I won't go through all of those, but I'll hopefully be able to give everyone an update when I've done some more analysis. And thank you to all of my supervisors and other support people.
Thank you, Rhea. That's amazing. We're open for questions. If anyone has any questions, please type them in. If you have a longer question or comment and you'd like to speak, you can let me know as well, and I can let that I can allow that to happen. Rhea, to start off with, this is a bit of a difficult question, but I thought I might ask you anyway, since you might have to think about this. How can you use your data to promote prescribing behavior change among vets, especially since your microbiological data confirms the current guideline recommendations?
It's a really good question. I don't know the answer exactly, but one thing I know is difficult for vets, and it's come out in the interviews, is that most of them, once they've left the cocoon of the university and gone out into practice, they actually don't have good access to scientific journals. The clinics don't pay for them. They've got very limited access through even if they are members of the Australian Veterinary Association, they have very limited access to journals. I guess, you know, it's a flip of your question. What doesn't work is probably just publishing stuff in scientific journals. I need other ways of getting this information out to vets. And one of the things that I'm working on with the lab that gave me all of this lovely data is changing the way that they report their susceptibility results, that gives vets a bit more guidance about what is a good first line choice. So I'm trying to get them to put in their reports, classify the susceptibility results under the importance ratings for the drugs, and with a bit of note and explanation of why say TMS would be a better choice than amoxiclav. So that's one idea, but I don't have all the answers.
No, that's amazing. Thanks, Rhea. Glenn has sent through a question. Rhea, how does resistance in dog and cat urinary isolates compare to that in human UTI isolates?
Well, in Australia, it seems that with the information that I've read so far seems to say that the E. coli, at least in human urinary isolates, is more resistant to amoxicillin and amoxicillin clavulanate compared with what we're seeing in the veterinary results. It's sometimes a little bit tricky to compare because this lab is using a particular technique in particular cutoffs, and it's not necessarily easy to know whether it's comparable to, say, a lab that's using a different method. But if we just look at the raw results, it would seem that the urinary results from humans suggest higher resistance to a few different drugs. So I think we're in a better position in the veterinary world compared to what GPs need to deal with.
Thanks, Ree. One more question for you, Ree. Administration is obviously a key concern now for vets and pet owners. Can that be the basis of an intervention, or can that be the target of an intervention?
Yeah. So one of the things that I'm exploring with the vet interviews is what vets think would be most helpful. Some of the vets have mentioned that they would like more resources to help explain to their clients how to, for example, give a pill to a dog or to a cat, which, I mean, I haven't explored that too deeply yet, but there are some things that have already been created, and some vets are doing it themselves, creating videos and putting them on YouTube to show their clients how to do that. In terms of compliance, I think one of the big things that will actually help with compliance, because we know that vets are using quite long courses for some things. A lot of the vets I spoke to were using courses of 2 weeks for a urinary tract infection. So if we can get across the guidelines are actually saying a much shorter course of antibiotics is required, just shortening the course to what it should be will actually, I think, help compliance a lot with, if owners only need to give 3 to 5 days of antibiotics, that's a lot easier for them to do than to give 14 days. So that's one of the key things that I would like to look at, getting through that. Actually, a lot of things that we're doing are possibly a little bit longer duration than the literature would suggest we need to.
Perfect. Thanks so much, Ree. I think we might move on to Jaclyn now. So our next speaker is Jaclyn Bishop. She's a PhD fellow at the National Centre for Antimicrobial Stewardship at the Department of Medicine at the University of Melbourne. And she's also a pharmacist at Ballarat Health Services. Jaclyn will today speak on the topic, a cellulitis bundle of care in 3 regional Victorian health services, preliminary findings. Thanks, Jaclyn. Yep, your slides are coming through perfectly. You might have to unmute yourself, Jaclyn.
Yep, sorry, just trying to do the technology in the right order.
Yep.
All right.
No, it's working well.
Okay, thank you, Arjun.
Thanks.
So thank you everyone for joining the presentation today. I'm presenting some information on behalf of the CELLLIT project team, and I'll be talking about our project around a cellulitis bundle of care. Okay, sorry, just getting the slides to move on. So the presentation today, I'll provide some background on the project and the activities so far. I'll talk about some of our achievements and talk about preliminary findings and the impressions from those. But there certainly are some current challenges and some next steps, and it'd be helpful for me to maybe get some feedback from those in attendance today. So undertaking research in regional and remote hospitals is one of the streams of the National Centre for Antimicrobial Stewardship, and it's great to be able to present this today as something where we've tried to work closely with regional and small regional hospitals to pilot an intervention. So why cellulitis? We previously looked at the National Antimicrobial Prescribing Survey data, the NAPS data, and compared it for regional and rural hospitals with major city hospitals. And cellulitis was one of the conditions that really stood out from the data. And we did find that there was a higher rate of inappropriate antibiotic prescribing for cellulitis in regional and remote hospitals compared to their major city counterparts. And that was considered statistically significant. But not only that, cellulitis was quite a common condition that was treated in regional and remote hospitals. So therefore, we were likely to get perhaps a bit more bang for buck by targeting a condition that was a very common one. So our research question was, can a cellulitis bundle of care improve the appropriateness of antibiotic prescribing for cellulitis? So we chose a bundle of care approach because there has been success with using bundle of care in other conditions that are also treated with antibiotics, such as reducing ventilator-acquired pneumonia. Sepsis is another one where a bundle of care has been quite successful. And a bundle of care is really a set of evidence-based actions that are intended to be completed for each and every patient on every occasion that care is provided. And we initially thought that that would fit nice and well with cellulitis. There are very clear antibiotic prescribing guidelines available here in Australia in the therapeutic guidelines, which have been fairly consistent for a long period of time, as well as a range of other non-pharmacological activities that you could undertake to try and improve the speed and also speed of the infection resolving, but also to prevent recurrence. So we went for a bundle of care approach. We were lucky enough to receive funding through Western Alliance for this project, and really what that allowed us to do was to have research officers at the 3 hospitals that are participating in the project. So I'll just share the timeline to date. The project commenced in January 2019, and in that first phase, as you can imagine, we spent developing our project plan and preparing our protocol. In May 2019, we started our baseline data collection at the 3 health services, and that continued through till November 2019, so around 7 months worth of data collection. During that time, we also co-designed a cellulitis resource that would be used at the 3 health services in the post phase. I'll call that the cellulitis plan just for ease of wording throughout the rest of the presentation. And that was launched in February 2020 at 2 of the sites, and 1 of the sites in March 2020. And then we began our post-data collection from March 2020 as well. As you will all know, there was a fairly significant health crisis that occurred in March 2020. So we'll have a discussion about that in terms of how it's impacted this particular project. So the bundle of care. So there wasn't a bundle of care in existence for cellulitis. So it was something that we created ourselves, the project team and the research officers. And the acronym that we came up with was CELLLIT. Originally it had 1 L, and then we had to put an extra L in there. So it still rolls off the tongue, I think, even with the extra L in there. And we had a fair amount of marketing and promotions that we put together for the launch of the resources, and that's the logo that you can see on the slide there as well. So what I'll do now is I'll just flick to the actual resource and I'll go through each of the elements of the bundle of care so you can see what it actually looks like in practice.
Jaclyn, we've the presentation stopped.
Okay, yep, what are you seeing now? Just nothing?
Just the, it's out of presentation mode. It's gone back to normal mode.
Sorry, my apologies.
No worries.
Okay, is the tool visible now?
Oh yes, yeah, the PDF, yeah.
Sorry, everyone. So this was the resource that we developed for the project. So the first section there relates to the first letter in the acronym for CELLLIT, and it's around confirming diagnosis and considering differential diagnosis. So particularly important for cellulitis is there's a number of mimics, and we wanted there to be some information available at the fingertips for the medical staff who were doing that assessment to really consider whether this was classic cellulitis or whether there was some other symptoms that they needed to examine in more detail. So we've got the common symptoms there, but also some differential diagnoses. We also included a statement that's included in the therapeutic guidelines around cellulitis taking up to 72 hours to show signs of improvement, and indicating that the fact that the cellulitis itself may look similar after 24 hours or 48 hours of antibiotic therapy doesn't mean that you should necessarily change that antibiotic if the patient is not deteriorating and seems to be improving with their other measures. So that was a really important measure that we wanted to be able to share. The second part of the bundle was that we wanted to evaluate severity and assess for danger signs. So this was particularly trying to rule out any patients that should be on the sepsis pathway because of any symptoms that they're showing. If there was any signs of necrotizing fasciitis, that should be considered and that this pathway would not be appropriate. We wanted to make sure that if it was an infection around in the area of a prosthesis, that orthopedics or surgery were involved with the discussions and ID review. And also if it was cellulitis that was in an unusual place, that should also be taken off this particular plan and ID support sought. The next part of the bundle is around location of care and antibiotic choice, and the location of care is probably more relevant for the larger site that had a short stay unit as well as hospital in the home and a ward options. So it was trying to guide the person making those decisions towards the tools that would help them decide on which location of care is appropriate, but certainly also for a consideration about whether oral antibiotics would also be appropriate. We provided some advice around baseline investigations and when a blood culture or a swab or tissue biopsy would be appropriate. And then I guess the antibiotic choice matrix is one of the key parts of this plan. And we set this up to be looking at the location of care as the first decision point. And then we've also used penicillin allergy as another decision point that we think is important in prescribing. So of course, we'd certainly like to be able to de-escalate penicillin allergies where possible, but at these hospitals, the resources and those programs aren't necessarily in place as yet. So we wanted to make sure that the allergy status of the patient was considered. There's certainly problems with people being prescribed penicillins when they do have a known severe allergy. So this dosing information is essentially from the antibiotic guidelines, but we have included some higher doses for oral therapy, and that was on the advice of the infectious diseases physician that were involved in the design of this particular resource. We've provided information around renal impairment, some guidance on when you might want to use a higher dose for oral antibiotics, and also some limited guidance around weight or extremes of weight, the information that I suppose is considered high enough quality to be able to include on a plan such as this. The third page of this particular document is looking at limb elevation. So we found in our baseline auditing that the limb elevation instructions from the medical officer was rarely, if ever, documented. And I suppose that leads on to the nursing staff also very rarely documenting whether the patient's limb was elevated or not. So we thought that was something hopefully quite simple that we could encourage through this plan to make it absolutely clear what the intention was and when that would be appropriate. And we also considered predisposing factors. So although this project is specifically looking at antibiotic therapy, we couldn't really put together a cellulitis resource without it including some of the conditions that are known to either be a source of entry for cellulitis into the layers of the skin, or something that can affect healing. So some of these can be managed as an inpatient, particularly a tinea pedis or dry skin. Others, we're just simply suggesting that referral happen to a lymphedema clinic, that obesity management programs be considered, etc. A space for notes and a little person to be able to draw the cellulitis onto. Then the final page of the tool, and this is a repeating tool, a repeating page. The idea of this is that it's a daily review, and we wanted to encourage the medical staff and nursing staff to consider whether all the follow-up actions have been addressed and considered again. But most importantly, from an antibiotic perspective, is an IV to oral switch and treatment duration review. And these are fairly generic guidelines around switching from IV to oral. We couldn't find anything specific for cellulitis per se, but we feel that they're certainly appropriate. And then total duration of therapy. There probably aren't a huge number of patients that have an extended length of stay with cellulitis, as I'll show in some of our data. But this is also important for discharge prescribing so that you can consider the exact quantity of capsules or tablets that you might need on discharge rather than just selecting the PBS quantity. We also included a nursing care section, and this would be where we'd like the nursing staff to indicate whether they've been implementing the limb elevation plan at the 3 shifts throughout the day, and also whether standard skin care was being attended, because that was certainly highlighted to us from our wound care colleagues at the 3 health services that this was something that could very simply be done that would make a big difference in terms of improving healing, but also preventing recurrence. Patient education was also important, and there's sections for both the medical staff and the nursing staff to document that. What I'll do now is I'll just switch to the patient leaflet that we developed for this project. So just bear with me while I bring that to the forefront. Okay, so this was the patient leaflet that we developed. It actually sits at the back of the cellulitis plan, and the idea was for this to be really a pictorial leaflet that would hopefully cater for a degree of health literacy that we know it exists within our populations. And a big shout out to one of my project officers who, other than this first photo, volunteered his legs for most of these pictures as well. So I won't show the whole leaflet in any detail, but just really to highlight that we wanted a pictorial style leaflet. We included phonetic pronunciation up there as well to help patients that sometimes struggle with using the term cellulitis. We had a spot for questions if the patient wanted to document down. And the sections are really what's going to happen while I'm in hospital, but importantly, what should I do when I'm at home and how do I manage that? Of course, we had a section about when they should seek medical advice as well, and some references for a couple of good websites for more information as well. And this leaflet really came about because there's some published literature from the UK that suggested that patients' knowledge of cellulitis before they have cellulitis can be a problem, but can also be an issue when they return home, that they don't have that information available to them. Okay, so I'll go back to the main presentation again now. Okay, so the 3 sites that were involved in this project, I'll just call them Site A, Site B, Site C, just for the anonymity at this point in time. But some of the positives were that we were able to have 3 sites that were quite different in their sizing and also in terms of the medical staff structure. So Site A was GP-led, Site B and Site C were both salaried medical staff. All of them had an AMS pharmacist, part-time capacity, but on-site ID specialist was only available at Site C. In terms of number of patients that were contributed to the baseline audit, you can certainly see there that Site C had the greatest number of patients, and do need to keep that in mind when looking at the information from the baseline audit in terms of interpretation. Outcome measures, excuse me. Our primary outcome was to be able to look at the appropriateness of antibiotic prescribing on day 1 and day 3, and we were using the NAPS method to do that. And our target was to increase appropriateness by 15%. So we used the NAPS figure as what we thought our baseline would be when designing the study, and that was 75% appropriateness. So we wanted to get that up to 90%. We've got a number of secondary outcome measures as well, and some of them are standard around readmission within 30 days of discharge, but we're specifically looking at readmission for cellulitis, length of stay, clinical costing. We're also doing follow-up phone calls with patients, so we are asking them about whether they feel they've had a relapse within 30 days of discharge. Looking at duration of IV antibiotics and discharge antibiotics. Looking at the bundle uptake itself, because as much as anything, this is an implementation study. So how many patients had the plan available, how many were provided with the leaflet, etc. And the last one there are a few that we added in around discharge antibiotic appropriateness, time to first antibiotic, because there's limited data around that for conditions such as cellulitis, and as I mentioned, patient satisfaction. So we use the REAIM framework essentially to develop our implementation and outcome measures. It is important to understand who's included in the audit and who isn't. It's only in adults, and they do need to be admitted to hospital. So this doesn't include those that are assessed in the emergency department or urgent care centre and return home without being admitted. And we also used ICD coding for lower limb cellulitis. Patients needed to have received an antibiotic to meet the criteria for the primary outcome. We didn't include anyone that was pregnant, and so far that was actually no patients have been admitted who were pregnant. For a statistical reason, we've only allowed patients to be included in the study once, so they can't contribute to the study more than once, even if they are readmitted for the same cellulitis condition. We did exclude those who are admitted to ICU, and that's really important to remember. This program, this resource is really designed to provide standard care to patients with fairly classic cellulitis, not those who have a range of serious comorbidities. And also, along those same lines, we did exclude those who were transferred to another hospital for escalation of care. We didn't include patients if they were transferred from another hospital because we would not know when their antibiotic therapy started. And we did come across a number of instances where someone was coded as cellulitis, but when reading the medical history, it was absolutely clear that the patient did not have cellulitis and they were excluded. So what are our achievements? And most of these are reflective achievements at this point, not necessarily with data to support them, but we were able to get a snapshot of cellulitis in our region across those 3 hospitals. 2 of them are in the Grampians region and 1 is in the southwest region of Victoria. So we do have a reasonable spread across those 3 hospitals. And we also collected a range of data that I won't present today around the patient's comorbidities, their presenting clinical factors, their allergy status, the features that were reported for their cellulitis. So we've got a lot of data that we'll be able to use. That has been reported previously within Australia, but we'll be able to do a compare and contrast with some of those earlier studies. For those of you that work in health services that aren't part of larger networks, you know how much duplication goes on with developing resources. So we're really proud that we were able to create a consistent resource across the 3 health services, and there was very little changes that were required across the organisations. It did take a little bit longer than we'd included in our project plan, but certainly we were able to incorporate co-design both from our patients for the leaflet and also the health services to develop that resource. As I mentioned, we've got 3 research officers at the 3 health services, and it's given them an opportunity to be involved in research and to be involved in an application for ethics and following data collection guides and tools, that sort of thing. So I think that's been a real positive from the funding that we were provided. And I do feel that we've produced a more consumer-friendly leaflet. I'll now just speak about some of the results that we've achieved so far, and I suppose perhaps speak as to why I feel we've achieved these results. So the uptake of the plan certainly has been less than we would have anticipated at this point in time. So we're about 3 months into our data collection. So the results are representing March, April and May. And we've had 26% of patients who meet our audit criteria having been commenced a plan. The run chart that I've shown you there is from Site C, which has certainly had the higher number of patients so far. You can see that there's quite a lot of inconsistency in terms of uptake. So this is showing the percentage of patients who should have had a plan that did have a plan started. And the median figure is really just sitting up above 10% at the moment with great variability. And we've set our goal at 90% for the uptake of the plan, certainly understanding that the plan's not appropriate for every patient that might meet our audit criteria. What are the reasons for this? Well, certainly we feel like we've been impacted by COVID. Early March, the attention of all the staff certainly went towards COVID preparations, and there really wasn't a lot of brain space left for much else. And it certainly limited our ability to re-engage with the staff and to be able to embed this particular resource during that time when really all other projects and activities were on hold. In terms of the patient leaflet, because that is attached to the resource, the uptake is similar. We have done a number of follow-up phone calls, and some promising results are that for those that received a leaflet, which is only 6 patients at this point in time, 100% of them rated the helpfulness of that leaflet at a 4 or a 5. So that was on a 5-point Likert scale, where the 5 is extremely helpful. In terms of their overall satisfaction with the information they were provided about cellulitis during their care, all of the patients that received the leaflet rated it a 4 or a 5. Whereas you can see for those that didn't receive the leaflet, 61% of them rated it a 4 or a 5. So we feel as though the leaflet, there's a trend at this point in time, is improving the satisfaction of patients with the information provided about cellulitis. And hopefully this will continue with further follow-up phone calls. In terms of appropriateness of antibiotic therapy, our baseline data showed that on day 1, 79% of prescriptions were appropriate. And you will remember that that's slightly higher than the figure that we predicted from the NAPS data. On day 3, there was a great improvement up to 87%. That improvement was consistent across all 3 of the sites, and the day 1 figure also was quite consistent across the 3 sites. The discharge figure was up at about 86%, although there was quite variation between the 3 sites, with site C, the larger site, having the highest value in the 80s, whereas the 2 other sites, one was in the mid-60s and one was in the low 70s. So it certainly highlighted that maybe at those 2 sites, a focus on discharge prescribing is important. In the post-collection data, so we've had 38 patients so far that we've been able to audit. On day 1, the appropriateness for those with the plan is sitting at 84%, with those without a plan, 80%. So that is a slight improvement for those with the plan, but the numbers are very low and they do change quite easily with a patient falling into one or the other category. Again, we are seeing some improvement by day 3, and certainly the day 3 figure is higher than those who did not have the plan. Probably the standout figure so far is on discharge, that there's been 81% of appropriate prescriptions being appropriate on discharge for those without a plan, but we've achieved 100% for those that did have a plan on discharge. So again, these are very early figures, but it is promising that those figures are showing some impact of the plan. Just quickly, one interesting finding that we found was that the length of stay was quite different across with Site C compared to Site A and Site B at baseline. So Site C had a length of stay of 2 days, whereas Site B and Site C had 4 days. When you look at the duration of IV therapy, which is in hours, Site C had a median IV antibiotic therapy duration of 24 hours, whereas Site B and Site C were around 2 days to 2.5 days. So that was certainly something that seemed to be linked between the length of stay and the duration of IV therapy. Looking at the post data, certainly Site C has still has a median length of stay that's shorter, and their duration of IV therapy has not changed. It's still at 24 hours. But what we have seen is that Site B has certainly has changed their duration of IV therapy, and they're now sitting down at about 24 hours. So that'll be something that'll be interesting to follow. So in conclusion, there have been a number of challenges, particularly around uptake of the tool, really in the COVID environment that we're working in. We've had reduced engagement opportunities, as I've said. We really haven't been able to be on site promoting the resource, and that's at the direction of our health services. And we certainly haven't felt comfortable being in the ED and trying to encourage this tool in that environment at this stage. We've certainly also seen a reduction in the number of patients that have come into the hospital with cellulitis. So before COVID, we probably would have had 8 to 10 patients that would have come up on our audit sheet as being potential patients. Now we're getting maybe 2 or 3 a week. And that's really having an impact on our numbers in terms of being able to show a difference. And I did mention that we made a decision in our planning to use independent samples, but really that combined with the lower patient numbers coming through means that we're not getting a huge number of patients in our sample. So what are our next steps? So re-engagement was certainly something that we've been doing over the last 6 weeks. However, with the change in circumstance with COVID now, I think the environment's changing and we may not be able to continue actively engaging as much as we would have liked to. So what we're really doing is now looking at some subsamples of our data to see what we could present, and time to first antibiotic is one of those that we've been looking at. And some of the analysis that we've done so far has shown that there's only a week association between time to first antibiotic and length of stay. And there doesn't appear to be an association between time to first antibiotic and 30-day readmission rate for cellulitis. So we're kind of putting that together to see how we can use some of the subsets of the data we've been collecting. And certainly we'll be continuing our data collection, and we've extended our research officers to the capacity that we've got in our funding to allow that to continue. So I will conclude there and just leave those acknowledgements up on the screen. Thank you very much.
Thank you, Jaclyn. Oh, I can hear an echo. Thanks so much. That was an excellent presentation, and it's great to hear an update about the project. We have a couple of questions already. Jaclyn, are you able to see the Q&A window?
I can now, yes.
All right, fantastic. So there's, yeah, maybe I'll let you read the questions as well.
Yeah, so they look like they're comments, so thank you for that. Just a comment about the visuals and the simple language that we've used on the cellulitis leaflet. And certainly we did a lot of piloting with consumers, and sort of ambushed them in the waiting room and provided the leaflet to them and got their feedback. So that was a really good experience, and yeah, it was fun creating the pictures as well, I say.
And did you see? Can you see the Q&A window, Jaclyn?
Yes, so there's a question there that was just asked about what is the target patient numbers for the study and how did we come to this figure. So certainly our sample size that we were anticipating achieving was 120 patients in the pre and the post. And we used that based on the plan of improving antibiotic prescribing by 15% from baseline, which was estimated to be 75%. So that was the sample that came through that particular figure. We will need to reanalyse that, and hopefully we can come up with some findings without having to achieve 120 in the post. I guess now we've also got the group that didn't receive the plan, that did receive, and compare that with those that did receive the plan, which is something I hadn't really thought about in our initial analysis plan. So I'll need to perhaps look at those three groups, but we certainly thought that we would have maybe some osmosis of effect coming across from the education that we did, and even just the doctor seeing the tool once and using it in one patient but not using it for the next patient, that there still might be some influence. Courtney's asked about an electronic form. We certainly had that discussion at the larger site that's got more experience with using e-forms than the two smaller sites. And the uptake of e-forms has been a little bit of a challenge, and the feedback that we got quite strongly initially was please do paper. So that's what we did, but we certainly have capacity to turn it into an e-form. We've got a template for that. So it was certainly something that we were going to look at if the paper version was successful. Yeah, happy for anyone to contact me if you'd like to have a copy of the leaflet. We're quite happy to share that, and it has gone through our consumer C-read process. So just look at your own processes for that. So I don't think I had my contact details on the website there on my presentation, but feel free to reach out on Twitter or through NCAS as well. Someone's asked about the ID specialist. So one site had an ID specialist on site per se. The others, I believe, have relationships with ID specialists that they can ask for advice where needed. But I'm not specifically across all of the details of that arrangement, but it's certainly something we were aware of when we prepared the leaflet, the tool, sorry, I've got the phone going off in the background. They still wanted the wording of consultant ID physician left on there rather than some other wording for their particular site. Someone's asked about implementation outcomes, acceptability and feasibility. Katie, thank you. Yes, we had designed a survey for staff about their use of the tool and whether they believed it changed their practice. And we also had designed some interview questions for key stakeholders. And those questions were around whether they thought it should be implemented in other organisations. If so, what would they change, etc. But we've put that on hold because of the uptake being so low, and also the impact on staff at the moment with COVID. We've got them sitting there ready to go. We're thinking probably of looking at doing that in November, probably November, to see if we can get some of that data there. So certainly through that RE-AIM framework that I mentioned, which is an implementation style framework, we've developed sort of elements that would cover all of those different components. Thank you for putting my email there in the chat. That's a great idea. Thank you.
Thanks so much, Jaclyn. I think you've got all the questions now. Yep, there were a couple of those questions about whether the leaflet can be shared with other hospitals. And I'm assuming that won't impact on your study, would it? For the resources. Yep.
No, I don't think so. No, we're happy to share.
Yep.
Yeah, maybe. Yeah, no, I can't see any reasons why that would be an issue for the study.
All right, fantastic. So we've gone past 9:30. Thank you so much, both Ree and Jaclyn, for excellent presentations today. And of course, we look forward to hearing more as you progress your PhDs and your various projects. Thanks very much again to everyone who attended, and we look forward to seeing you next month. All right, thank you, everyone.
Thank you.
Bye-bye.
Bye.